Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Respiratory Issues, Episode 3, Bronchiolitis. After viewing this episode, participants will review the pathophysiology of bronchiolitis. Participants will also review the identification and assessment of bronchiolitis. Finally, participants will review the pre-hospital management of bronchiolitis.
Bronchiolitis is caused by a virus, and it can often have symptoms that are similar to asthma. It's often in the younger children, in the younger age groups, and it's caught from a transmitted virus.
Bronchiolitis is a pretty common diagnosis, but to say you can see bronchiolitis in the field is probably a bad representation. Bronchiolitis, inflammation of your bronchioles, is way down in your lungs and you can't see it. There's a lot of things that can cause it. RSV is probably the biggest piece. But what you're really looking for, as you would in any respiratory patient, are they having trouble breathing and are they getting enough oxygen? So you probably see a lot of bronchiolitis in the field and have no idea that's what it is.
Similar to asthma, bronchiolitis can cause some bronchoconstriction in the respiratory system. And bronchiolitis is most commonly caused by the virus called RSV. And in children, the infant age group is most susceptible to bronchiolitis. Bronchiolitis, in fact, will often cause a necessary admission to the hospital in children in this age group.
Bronchiolitis is most dangerous to the younger population. And so you could probably walk around with bronchiolitis, tell everybody you have a cold, and you'd do fine. But children, especially children under the age of 1, are at risk for apnea because of bronchiolitis.
Bronchiolitis is an inflammation of the bronchioles. It is most commonly caused by the virus RSV. It causes bronchial constriction similar to asthma. You'll see more severe symptoms in infants, and it may require hospitalization.
Bronchiolitis is often assessed or noticed by the presence of wheezing and increased respiratory distress. And it's distinguished from some other respiratory problems like asthma in that steroids rarely help bronchiolitis. And although beta agonists like albuterol are used in bronchiolitis, they sometimes can have some limited utility as well.
Bronchiolitis is another viral type of illness. We see it, and NEBs don't usually help with bronchiolitis. So if EMS are listening to the lungs and they hear a lot of scattered crackles, it probably is bronchiolitis and it's viral. But it's the young kids, the infants, who may need to have oxygen. That's why they get admitted, is for oxygen. And sometimes if there's a little bit of wheeze, they'll get treatments, but mainly it's to monitor their respiratory status. So that's something that EMS is helpful for them to differentiate, is the crackling is a good sign of bronchiolitis.
Bronchiolitis is not as common that I'm aware of as asthma per se in the pediatric population. Sometimes it's almost synonymous though. I've heard people interchangeably use the word bronchiolitis in asthma, probably because they haven't been diagnosed officially with asthma. My understanding is that to identify bronchiolitis, it presents similar to asthma. They'll have wheezing, cough. It's just an inflammation process.
Respiratory-wise, and pulse-wise for that matter. It's important that we know that the normal signs are in the normal range, or if they're not, that the child was crying or fighting you. But every child who's crying has vital signs. So it's important for us to know what their respiratory rate is, what their quality of respirations are, and what their heart rate are. In the pre-hospital setting, any patient on a respiratory call you would treat the same way. What is their work of breathing, and how are they oxygenating? And do they need help? So you check their SAT. You look at their bellies and their chest and their neck and see if there's different muscles than somebody who's breathing normally. And you check their respiratory rate. Any of those things that you can support, you do. You can give breathing treatments. They may or may not help, but sometimes it's one of the differentiations between, is it an asthma attack or is it bronchiolitis? Or when we gave them a neb, it stopped. So assessment of the work of breathing and the quality of breathing, the rate of breathing, and then any intervention that you have, did it work, are very important.
Bronchiolitis can present with wheezing, respiratory distress. It rarely responds to steroids. Vital signs are very important in respiratory issues. If you cannot obtain vital signs, document the barriers to obtaining them.
Pre-hospital management of bronchiolitis is essentially supportive care. Following your protocols, some systems may have you give saline nebs or maybe even albuterol nebs, but oxygenation is probably the most important thing in bronchiolitis.
To treat a pediatric patient who presents with bronchiolitis, is mostly supportive. It's supplemental oxygen. You can consider nebulizers of albuterol or ibuprofen bromide if they present with wheezing.
Again, you probably won't know it's bronchiolitis in the field, but treat it like every other respiratory distress call you're going to see. Oxygen if needed, position of comfort to breathe, and calling ALS if you feel that the patient is tiring out.
Management of bronchiolitis is the same as any other respiratory issue. This includes supplemental oxygen, supportive care, and nebulized treatment if necessary. Bronchiolitis may have limited response to treatments, and don't forget to continue with routine care. After viewing this episode, participants will review the pathophysiology of bronchiolitis. Participants will also review the identification and assessment of bronchiolitis. Finally, participants will review the pre-hospital management of bronchiolitis.